Hello, good evening. How are you? Welcome to another session of Ask the Doctors. I believe you can hear me, right? Yes, my name is Dr. Frederick Unuigbokhai, and I'll always tell you good life in a sense. Now, this is Ask the Doctors, a health program that goes on every Sunday, 8 p.m. West African time. And if you're watching this video, you're welcome. I see some people joining us. Yes, how are you? Welcome. Where are you joining me from? Good evening and welcome. How are you? We have some people already in the house. So let me give you a shout out. Hello, drop your name and where you're joining me from. How are you? Good evening. So with this program, I'm usually not alone. I have my co-host, my colleagues, Dr. Blessing, Dr. Israel. And today we're talking about something very, very interesting. We are talking about infertility. Hmm. We are talking about infertility. Yeah, Grace, I see you. How are you doing? I'm expecting my guest to join us very, very soon. Grace is here. Alex from Norway. Grace, how are you? Please share this video, share the live stream. Let's get as much people as we can get here. Festus from Lagos. Okay. Augusta from Oman East. Augusta, how are you? Lizzie, hi. I see you all. Welcome, everybody. So please share this live stream, share this video, share the video. We're talking about infertility tonight. So all your questions on infertility, please get your pen and paper and jot them down because we'll do our best to take your questions tonight. Okay. Yes, yes. I see my people. And very good eating fresh food, so I don't sleep up. Okay. Khadija from Sierra Leone. Khadija is watching us from Sierra Leone. Good evening. Victor from Imo State. Nice. I see you all. Welcome, 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 welcome. Okay. So we're trying to get our guests in here. Gilbert, Anita. How are you, Anita? Please, everybody, share this live stream. Let's share the video. Let's share the video. Uh, let's share the video. Okay, my guest is ready. He's ready. He's joining us very soon. I just got a message from him. Jessica Okoro, how are you? May I share the video? Olivia, how are you? Yes, 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 yes. Uh, I see you all. We're waiting for him to join us. So many questions tonight. Yes. Who again do we have here? Who again do we have here? Amedu Charles has shared the live. Charles, thank you for sharing. God bless you. Oh yeah, ladies and gentlemen, please share this video here. That is how he supports me. Share the video. Let's see. Let's see how many people have shared. 4 people have shared this video. Just 4 out of 90. Okay. Hi, good evening. Welcome. How is your Sunday going? So this program is every Sunday, as you can see, 8 p.m. By the grace of God, we have always been here. Belle Love Gold, how are you? So if this is your first time joining us, you're welcome. I don't share and so thank you for sharing. God bless you. If this is your first time joining us, you're welcome. My name is Dr. Frederick Unuigbokhai. Um, Good evening, Anita. And I'll always say good life. I said, I have this program together with my colleagues. I'm expecting them to join me very soon. Ruth, how are you? I have shared. Thank you for sharing. Now, this program is all about health. We have guests joining us in the program. Sometimes no guests. We are alone. We interact with you, answer your questions. It's 8 p.m. West African time. Let's see what we have here. Okay. What's happening? Yeah, now join me, join me, join me. I'm looking for you, sir. Yeah, happy Sunday, Tony. I have shared. Thank you for sharing. Okay. So I noticed that a lot of people have been complaining about infertility. Uh, Good evening, Trace. I got married and trying to get pregnant, and it's not possible. What is the problem? So I decided to speak with a consultant, and he decided to join us today. So I'm expecting him to join us tonight. We're waiting for him. So if you have any questions, if you have anyone around you that you believe will benefit from this program, please tag them to this post and then join us. Huh? Yeah, I'm still waiting. Hmm, Let's see. Okay. Let's see. What's happening? Why have they not joined? What's going on? Hmm. Oh, wow. Oh, my God. Oh, wow. Okay. Let's see. Okay, yes. Let's see who else we can do now. My line is breaking. Really, my line is breaking. Dr. Israel. Dr. Israel, how are you?
Fine. Good evening. Happy Sunday.
Happy Sunday. Happy Sunday. Dr. Blessing, how are you?
Dr.
Happy
Blessing.
Sunday, good
No.
evening. Yeah, Dr. Israel, good evening, happy Sunday. It's been a long while.
Okay.
It's been a very long time.
So
Yeah,
we have Dr. Okoeguale joining us with a normal Facebook link. No, sir, you're supposed to join us with the link I sent to you. Good evening, sir. I sent you a special link. You're supposed to join us with that link, sir. Let me see. Um, Let me see. There is a link, yes. So, uh, how has been your day now, Dr. Blessing?
we see I'm at work right now. So, yeah, still to me, the day every moment is a day, it's maybe night to you, but I'm still to me it's still day. So because I'm actually still working. Yeah.
Yeah, I understand. Dr. Israel, how is family now?
Yeah, family is fine. We are doing well.
Dr.
Okay.
Israel, my guy.
So we have 22 people joining us right now. So I want to appeal to every one of you, please share this video, and our guest is coming up very soon. Uh, I'm using- what's happening? What's going on? Oh no, oh God, why now? Okay, I think I will have to mute my own mic. Then I need to send him a message. Like, she is not joining us with the link I sent. Hmm, interesting. Good evening. Good evening. Um, I'll be right back. I'm coming. Let's see. Can you hear me, guys?
Yeah, we can
I
hear
can
you.
hear
I
you.
can hear you clearly.
Okay. Uh, I don't know. I sent the link, and he's yet to join us with that link. So we are all waiting for him. He's online though. I guess he hasn't used such link before. Emily Obaro. Okay, yes. Now we have Dr. Who do we have here? Yes. Okay, yeah. Good evening, sir. Now,
Hello, good evening. Sorry, I was struggling to use this link. I joined with the regular Facebook. I actually wanted to use my laptop, but this is my phone. I was using my laptop. But if you give me like 2 minutes, I can send this into my email and then see whether I can connect with my laptop.
Okay, no problem, sir. We'll wait for
give
you,
me.
sir.
Okay, all right, thank you.
Yes, sir. Okay. So, good evening, everybody. Welcome. Apologies, Apologies. We just saw our guest come online this evening. So these are some of the things we want to talk about tonight. We want to talk about what causes infertility, number one. And there's this question I keep hearing. Matilda, how are you? Someone says, I have given birth. My last child is 5 years, 6 years, 7 years, yet I can't get pregnant again. What is the problem? These are some of the things we'll be looking at tonight. And then if you have any questions, please jot them down because Dr. Israel and Dr. Blessing will be reading all your questions. As many questions as you have, please drop them. Okay, let's do this, everybody, tonight. Tell us in the comment section, what do you think is infertility? What causes infertility? Let's see. Let's see. Dr. Israel, what do you think about that? Let's interact, right? Let's speak with them. What do you think causes infertility, ladies and gentlemen? Tell us. Don't go to Google. Okay, we're good to go. Good evening,
Can
sir.
you see me? Can anyone see?
Dr. Blessing, I can see you, but your camera is hidden. Dr. Joseph, good evening, sir. Okay, we can't hear you. Maybe your mic is muted, Chief. I think your mic is muted. You would have to.
All right.
I think
I'm back online now.
Yes, you're back.
Sorry, I'm still.
Okay.
Dr. Fred,
Yes,
I want
sir.
to thank you and your team for choosing this topic. It's quite a topical one. Infertility is very topical because of the issues associated with it. So I'm actually looking forward to a very interactive discussion because I know very well that many of us have some knowledge base, our perception, our experiences, and all that, like our shared experiences about infertility. So it's going to be very interactive.
Thank you so much for joining us tonight. We appreciate your time, sir. Welcome, everybody. Good evening. Joining us tonight is Dr. Joseph Okoeguale. You can see his name on the screen. He is a consultant obstetrician and gynecologist at the Ira Specialist Teaching Hospital, Ira, Edo State, Nigeria. He's also the lead obstetrician and the deputy director of the Institute of Viral Hemorrhagic Fever and Emergent Pathogens at the Ira Specialist Teaching Hospital. We had to plead with him to provide us this time so that we can talk about this very interesting topic. So, sir, without wasting time tonight, as Africans, there is this belief that when a couple gets married, immediately they must get pregnant. When there is no conception, there is no pregnancy, the woman is blamed. She begins to panic. So we want you to help us. What is infertility and why should Africans stop this mentality of putting pressure on newly wedded?
I just switched to
I think he has dropped off again.
Okay.
Chief has dropped off.
You can see me now, right?
Yes.
Yeah, we can see you.
Okay, I have to switch to my laptop. I hope this is actually a better option for me. If not, I will switch back. Let me just use this for a while.
Yes, it's better, sir.
I'll just quickly start by, first of all, defining what infertility is all about. Infertility is inability of a couple. You underline that word, couple. Inability of a couple to achieve successful pregnancy after 1 year of unprotected sexual intercourse. When I say couple, I actually mean couple of opposite sex. You know, a lot of things are currently happening worldwide, particularly in the developed part of the world, where you have a male living with a male and calling themselves couple, or you have a female living with a female calling themselves couple. So in this definition, I'm actually referring to a man living with a woman. And this couple are having sexual intercourse, regular sexual intercourse, an intercourse that is regular, an intercourse that is penetrative. That means there's a penetration, the penis penetrates the vagina, not an intercourse that involves penetration of the anus, the rectum, or any other part of the body. And there's ejaculation and deposition of the sperm into the vagina. That's actually what I'm trying to describe. So that will be very clear on what we are talking about. It's only in that scenario that you can talk about infertility. So the terms have to be properly defined. And then before I proceed, I want to quickly mention some other terms that we commonly use. Fertility, when you say fertility, it's just the capacity of being fertile. And then there's another definition called fecundability. That is the probability of a couple getting pregnant per month. It's relatively constant. It's relatively constant worldwide, and it's just about 20 to 25% if there are no issues. The chances that a couple gets pregnant per month is just about 20 to 25%. Now, inability to get pregnant is a worldwide problem. It's not limited to Africa alone. It's not limited to Nigeria alone. It's a worldwide problem. And it affects about 5 to 20% of all couples. It affects about 5 to 20% of all couples. So it's a worldwide problem. And both male and female have their contribution towards the inability to achieve pregnancy. It's not a woman thing. As a matter of fact, males contribute more to infertility as compared to females alone. Males contribute over 35% of cases of inability of a couple to achieve pregnancy. Females contribute about 25%, and then we have both factors. Contribution from both the male and the female contributing about 25%. Then in some cases, you can't find the actual cause. You can't find the actual cause of the inability to achieve pregnancy. The actual cause of infertility will be unknown in about 15% of cases. So it's a male and a female factor. And then it's also important for us to understand that there are also two types of infertility. It could be primary infertility, it could be secondary infertility. Primary infertility often results from the fact that the couples have never achieved any pregnancy since they got married. They have been married, but they have never been pregnant. Secondary infertility occurs in a scenario where a couple may have achieved pregnancy. But over time, the pregnancy probably did not end well, or it may have ended well, but they want another pregnancy. Do you get what I'm saying? I'm trying to, the scenario I'm trying to end. Yeah. It's secondary because they have achieved pregnancy before. Either it resulted to a miscarriage or they even have a living baby. They're now wanting to have another pregnancy. So it becomes secondary because they have actually achieved pregnancy in the past. So that is just it. And then the causes of infertility could whether be male factor or a female factor. The factors can result from problems in the male, that's the man, and then some problems in the female. This has to be well documented for you to understand, the issues around infertility, and not focusing your attention on just a particular, just one arm, because a couple is made up of the two arms, the male and the female. So your investigative modality have to be directed to both the male and that of the female, because the causes cut across the both of them.
Thank you very much, sir. For those that are joining us, you're welcome. Talking about infertility. Sir, from the definition you gave about infertility, you said a couple, regular, unprotected intercourse for 1 year, and they're unable to conceive for 1 year.
At least now, 1 year. At least 1 year. Yes. There's a reason why we said 1 year. There's a reason why we said 1 year. Okay. The fact is that I told you fecundability rate, that's the probability of achieving pregnancy per menstrual cycle, is just about 20 to 25%. Cumulatively, for a couple, the chances of achieving successful pregnancy can be up to 85 to 90% after 1 year, if there are no issues. So oftentimes, if there are no problems and couples are just getting married, you encourage them to continue to try, at least for the first 1 year, because we still believe that spontaneous conception has its own advantage. It's more satisfying as compared to probably assisted in many instances. So we allow the couple to just try for the first 1 year, before investigation, except when indicated. There are scenarios in which you may want to investigate earlier before it gets to 1 year. For instance, if the couple, are advanced in age, take for instance, the woman is over 35 years, you will be waiting for them to get to 1 year before you start finding why they haven't gotten pregnant, or they have, a background medical condition, and they are having delay in getting pregnant. You won't be waiting up to 1 year for you to commence investigative modality. That's just the reason. The chances increase by the second year. By the end of the second year, the chances increases by over 95% if you allow them to try spontaneously. So that 1 year is very key.
Very important. This is very important, because I see newly wedded lady tells me that she just got married 3 months ago, and she's already panicking that she's not pregnant. Got married 6 months ago, and she's already panicking. So it's important that we all understand the place of 1 year. You have to wait, especially if you are not up to 35 or you don't have any problem. So, sir, let's go forward. What are those causes of infertility? Let's start with the male, and then maybe we go to the female. Since from your definition, you said it's commoner among the males, 35%.
Yes. Male infertility contributes significantly to the problem of infertility. I also understand that culturally, most males are very reluctant to present themselves for investigations that has when it comes to infertility. Yes. In a fertility clinic, you have many males, telling the women, please go and get your fertility test done. I've impregnated over 14 women. I've impregnated over 15 women. I'm very fertile. So there is this very high level of inertia that, in many aspects, at many times, most of them will not want to present to the hospital for a check. But it's important to know that investigative modalities for male infertility are very cheap and easy. That's why we usually request for it first. A simple seminal fluid analysis, just a sperm test, will give you, it's very revealing. So it can show quite a lot, as to why probably there's any male factor, as to why probably, there's a challenge or there's a problem in having in being able to achieve a conception. If there's a low sperm count, there's a problem with the morphology, there's a problem with the motility and all that. And sperm production is an integral part, of fertility in males. And you understand that the sperm is produced by the testes, under appropriate hormones, in testosterone being released by the Leydig cell, stimulation of the seminiferous tubules, and production of spermatozoa. All those are now transported to the epididymis for maturation and storage. So you have a scenario where the sperm has to be produced. Another scenario in which the sperm has to be transported from where it is produced to where it can be stored. And then once it's stored, the maturation process continues. Now, after that storage, you need appropriate arousal for the man to be aroused and have erection, isn't it? For the sperm to now be released. So you have production, you have maturation, you have arousal and ejaculation, and then you have ejaculation, adequate deposition of the sperm into the vagina and transport to meet the release oocyte for fertilization to occur. This process have to be intact, all from the point of production through the point of maturation, through the point of ejaculation, arousal and erection has to be intact. Any problem with any of this line can lead to male factor infertility, and they can be very common. If there are issues with the testes, they're going to have problems. If they are varicocele, they are going to be problems. So in a scenario whereby, there are other conditions a man could have. Those are just external conditions, such as, some illnesses, diabetes, hypertension, and all that. Men who are on chronic medications, some of them can affect erectile function, difficulty with erection, diabetes, and hypertensive disease. And some men on chronic medication can actually affect arousal and erection. Men who take excessive alcohol could have problem with arousal and ejaculation. Men who smoke certain substances, they could also have that. And the exposure to toxins, exposure to irradiation, and then surgeries. There are particularly surgeries that could reduce, the fertility rate of some men, particularly some pelvic surgeries, herniorrhaphy, prostatectomy, many pelvic surgeries in male will. So that is why when you are evaluating males for fertility issues, it's important that you take this appropriate history and be sure, the man does not have some of these things I'm mentioning now. And then doesn't also have some, medical conditions like hypertension, diabetes, and not on some chronic medication, which have been known to affect erectile functions of these men. So these are very important. And then for the female, a couple of factors could result to difficulty with achieving pregnancy. A couple of factors. this could range from factors that can affect the womb of the woman, and then some external factors too. So some factors such as tubal blockage. You've heard a scenario where women will be told that your tubes are blocked, and the chances of getting pregnant is very low. It's common. It's a major contributor to secondary infertility in developing part of the world. The commonest cause of tubal blockage in many developing parts of the world is previous pelvic infections. Previous pelvic infections which were not properly treated, such as pelvic inflammatory diseases, post-abortal sepsis. Women have regular abortions without taking proper treatment, get infected, have an upper genital tract infection, and then subsequently have tubal blockage. It's one of the commonest cause of secondary infertility you will have. It contributes over 40% of cases of secondary infertility. It's common, very, very common, tubal factor infertility. And then you can have uterine factors, presence of certain masses, such as a mass within the uterine cavity like a fibroid. Fibroids are not known causes of infertility, but they can contribute so much in a woman becoming infertile. For instance, if the fibroid is occupying the cavity of the uterus, even when fertilization occurs, implantation becomes very difficult. So it then contributes to the woman having difficulty actually getting pregnant, or even when the woman gets pregnant, the risk of miscarriage becomes very high. And then if there are problems with the neck of the womb, the woman can also have recurrent pregnancy losses, even when the pregnancy occurs. And then other factors such as anovulatory cycles. Some women are not ovulating. There are some problems, which result from polycystic ovarian diseases. It's just a complex of problems resulting to anovulatory cycles. Women don't ovulate, and of course, they won't be able to get pregnant. So those are some of the factors. But in all these, there are some factors that impact negatively on the chances of getting pregnant. One of it is actually age. As age advances, the quality of normal ovarian follicles begins to decline. And once that happens, the chances of spontaneous pregnancy is so low, is reduced. Not just females alone, it also affects males. As males also advances, the chances of them, impregnating women also reduces. The quality of sperm also goes down. So it's not limited to women alone. So it's still male, female factor. And then apart from this, you could have a situation where you will have a combination of both male and female factor. A woman having tubal blockage and the man having sperm abnormality. So when you target the tubes alone, you discover that the man still has an abnormality in the sperm, and you are back to square one. You can have where women have uterine factor infertility and male, the sperm are having issue, having inadequate sperm and all that, sperm abnormalities. So you must target the male and the female in your investigation for inability to get pregnant.
Thank you very much. I already see some questions. We'll be taking your questions very, very soon. So I want to ask one question. A man and his partner, they presented to the hospital. They have been seen by a specialist. They discovered that there is no problem between the both of them. What would be your advice after seeing the doctor? There is no problem in the man, there is no problem in the woman. What would you advise them to do?
There are many things you still have to consider. There are many things you have to consider. First, you are taking the history from the couple. The duration of the marriage is key. If they have been married for just the past 1 year, you've done your investigation. You've checked the man is very okay. You've checked the woman. You've done all your investigations and they are okay. You are going to give them options, all the options, the fertility options that you have after your full evaluation. One of it is probably to start to find a way, probably to enhance the woman's ability to ovulate. You may just want to try that. No one will immediately go towards the side of having, discussing assisted conception for such couple. You just give some more time. But what if there are couples that have been married for 5, 6, 7 years and all that are coming to you? What comes to your mind is that, yes, this couple may have taken so many medications, a couple of drugs. In fact, before some of these people come to you, they have taken a couple of drugs. They have gone over the counter. They have bought clomiphene citrate and a couple of other drugs, a couple of other medications, even before they come to you. So you are going to look at them and see how much you can actually help them. If the infertility is still probably early, not more than 2 years, not more than 3 years, okay, probably let me try and do a follicular tracking and even see if this woman is actually producing producing eggs and all that. Let me just see if I could be of help. You can place them on some ovulation inducing medication for a period of 6 months and just wait and see what happens. If after 6 months to 1 year of your intensive trying to help and nothing still work, and that's when you begin to discuss other alternatives, other options. In fact, at the time you are seeing the couple, you're already discussing it, but you are going to reassure them, yes, that you are optimistic that within the next six months to 1 year, they'll probably be able to conceive with your intervention, because you are not doing active intervention. You are monitoring them, doing your follicular tracking, and trying to time the ovulation and see how much of that can help. So that's what you actually do. So many factors come into play at that time. If it's a long-standing infertility, it's important to begin to counsel earlier for assisted reproductive technology if need be. If it's a long-standing infertility, particularly when the couples have received several treatments and it's still not working. I just want to mention that the treatment of infertility in current day practice is at the mercy of several technology, such that there's no couple that cannot get pregnant. The only problem is that because it's just an expensive voyage, because in developing part of the world, like in Nigeria, patients will have to pay out of their pocket. Fertility investigations or treatment are not on any government program. No health maintenance organization pays for fertility investigations and treatment. Government doesn't pay for it. It's expensive. So even those without womb can actually get pregnant in current day practice. Place of surrogacy is there, remember. So everybody can actually get pregnant. That is why the chances, it actually depends on how committed the couple is. It's part of your fertility counseling not to allow the couple to give up, because a lot of things comes with inability to get pregnant. A couple of psychosocial problems come with it. It comes with it. So that counseling is very key at the time you are seeing those patients, that couple in your clinic. And that's why the couple has to be seen together. When you keep seeing the woman alone, please always encourage her to come into that clinic with the husband. Infertility is a couple problem. It's not the woman's problem, neither is it the man's problem. It's a couple. So you have to see both together and counsel them appropriately and give them some hope that there's nobody that can get pregnant in this life.
I like this statement you said. Yes, there is nobody that can get pregnant in this life with the knowledge we have right now in medicine. And it's a couple thing. So, sir, before we take questions right now, please, you can start dropping your questions. Dr. Blessing, Dr. Israel will be reading your questions. Before we go to the questions, I want to ask hormonal imbalance and the place of infertility. Let me say this. Someone was diagnosed, he has hormonal imbalance, she was placed on some medications. She's expecting that immediately she starts this medication, she's supposed to get pregnant. What should any woman who is currently on hormonal treatment for hormonal imbalance with regards to infertility, what should she know and what should she be looking at?
Okay. In evaluation for infertility, there are basic investigations that are requested for. I call them basic because in any case, you are going to get back to those investigations. The very first one you request for is a sperm analysis, as I mentioned earlier. Even if the woman has been told that her problem is hormonal problem, you have to go back to check the man's sperm because it's easy, it's inexpensive, it's cheap, it's easy to carry out. You will request for an SFA to exclude male factor. Now, for the female, there are basic investigations you will do. One of the investigations is a hormonal profile. A hormonal profile. You check her to check if she is ovulating, her follicle stimulating hormone, her luteinizing hormone, you check her estradiol level, and then probably you check her day 21 progesterone level. And of course, prolactin and a couple of other hormones you may want to check for. You do your hormonal profile. Now, your hormonal profile probably may tell you the kind of hormonal abnormality that woman is having. For example, a woman with polycystic ovarian disease, a polycystic ovarian syndrome, may have reversal of luteinizing hormone as compared to follicle stimulating hormone. So when you see the picture of the hormones, it may be able to tell you something, yes, that probably this may be in keeping with polycystic ovarian syndrome, which is the commonest cause of anovulatory infertility in women. That may now be backed up with an ultrasound scan you are going to do. When you are performing an ultrasound scan for infertile couple, you are very careful because you look out for several things. One of the things you look out for is to be sure that the woman does not have some factors in the womb that may prevent her from having a successful pregnancy. Some of those factors will include uterine fibroid. Some of those factors will include adenomyosis, and some of those factors will include endometriosis. Endometriosis is a common cause. It's a common cause of pelvic-related problem that can cause infertility. Once a woman has endometriosis, the chances that you have pelvic bands and adhesions, pelvic adhesions, and of course, pelvic bands blocking the tubes are high. So the woman can have tubal blockage from endometriosis. So ovarian endometriosis can be there. So apart from performing a pelvic ultrasound scan, a transvaginal ultrasound scan becomes also very important because a transvaginal scan will help you look at the ovaries very well. It's very key and strategic for you to look at the ovaries very well to check for ovarian issues that may be there. And if you time it very well, you may be able to see if the woman has ovulated or not, depending on the time you are doing the transvaginal scan. So the hormonal profile, the transvaginal scan,
your pelvis scan, and then investigations to assess tubal patency. A woman can keep saying that she's having hormonal imbalance, whereas what she actually have is the tubes are blocked. Making diagnosis of tubal factor infertility has to start from history. The woman has had recurrent past previous infection which were poorly treated. An infection you treated with 100 naira per ampiclos or 100 naira whatever, or you has had several D&Cs, and of course with post-abortal sepsis, post-abortal infection leading to upper genital tract infection, and the woman having tubal blockage. Those issues are there. And then outside that, their real uterine factor, which is called intrauterine adhesions, uterine synechia, which can result from problems that have resulted from either infection of the uterine endometrium or from several repeated endometrial curettage that have now led to formation of several adhesions within the uterine cavity. This can be checked by just doing a hysterosalpingography. But outside an hysterosalpingography, you can do a laparoscopy and dye test. You know, an HSG and laparoscopy and dye test can actually be done together, as there are two mutually exclusive investigations that can be done to confirm tubal factor infertility. But my point is this. Even if a woman tells you that she has been told she has hormonal problem, it's important you do this basic investigation. It's important that you also check the male. That male factor is very key. You will check the male. Go back to the woman. Check her tubes if they are open, if they are patent. Check the cavity if it's okay. Check for all other causes of infertility.
Thank you, sir. So let's go. Let's go quickly.
No, let me, comment. Dr. Fred. Yes, we are going to the comment. I actually have 3 questions to ask, but we have been people have been asking lots of questions. I think maybe it's best we should attend to those questions. Chief, you know, you know, I don't know what to say. Anytime I'm, on this program, I mean, listening to you, it's always a pleasure. So because of time, Chief, let's just take some questions. We have a couple of them. The first one, let's see, Mary John has asked a question since.
Wait, let's see.
Can you hear me?
Is it Mary John? Yeah, okay, see, here is it. Yeah, I can hear you.
Okay, so Mary John is asking, I find it difficult to get pregnant again after a birth of a son in 2018. So I don't know why doctor helped me. I have done hormone profile tests, infection tests too. Yes, so this is her own concern. She's saying she found it difficult to get pregnant in 2018. Maybe she's asking about what you should do. I think you've addressed this thing, but maybe you should just throw more light to it. Briefly, Chief.
Okay. I don't know who this person is seeing. I hope she is also seeing a gynecologist, and the couple are making frantic efforts, to get appropriate investigation from not just a doctor, because it's taking some time now. It's important to understand what level of investigation they've actually had and who is overseeing whatever they are seeing. I must mention that seeing a gynecologist in Nigeria is relatively cheap as compared to many other places you may want to go to. I'm not sure there's any teaching institution, any tertiary institution that do not have clinic days where gynecologists are present to actually attend to people who have issues like this. This is very key. And then it's important that this, this is investigated, and it depends, because sometimes some people get pregnant, they want to wait for some time before achieving another pregnancy. So by 2018 to 2022 is quite a long time. I don't know how long the person also breastfed, because period of breastfeeding, you may have some anovulatory cycles and all that. That's why we still maintain that she need to visit the hospital to get proper evaluation, proper review, and then appropriate investigations to be conducted on this patient. But definitely the fact that the couple have been able to get pregnant before and achieve the live birth, the chances are also high that following investigations and appropriate intervention, the chance of getting pregnant is quite high. So I would just encourage the person to probably get into a hospital where there's a gynecologist for full evaluation. It won't cost her anything. It won't actually cost the couple anything to get fully investigated.
Okay, so
the hormonal profile alone, the hormonal profile alone and the infection test is not so sufficient. And even the hormonal profile have to be properly evaluated, to see what kind of abnormality it is. That's only when you can now know what type of intervention you need to apply at that time.
Okay. Thank you very much, sir. So Mary John, please take the advice, seek a gynecologist, and then you heard what Chief said. So Veronica Emerenes is asking, how can one increase the chance of ovulation?
Is she married?
She didn't state that. if she's married
if she's
or
not married, if she's not married, you shouldn't bother so much about it. A woman who has regular menstrual flow every month, who has mid-cycle pain, sometimes mid-cycle breast fullness. Hello? Can you hear me?
We can hear you.
Okay.
Yeah, we can hear
All
you.
right,
I
okay.
think.
Yes,
all right.
we can hear
I
you.
said women who have regular menstrual pattern, who have established monthly regular menstrual flow, and then who have this regular mid-cycle pain and sometimes breast fullness are very likely to be ovulating every month. When a woman sees her period every month, the chances that she ovulates every month is very, very high. Are you getting it? Pregnancy is actually the only short test of ovulation, but when you see your period every month, sometimes you have mid-cycle pain, mid-cycle breast pain, sometimes mid-cycle spotting. You can spot blood around the mid-cycle. The chances that you ovulate are very high. Now, there are certain conditions, that you want to say that the chances of ovulation may be low for some women. For instance, women who are very big, women who are obese, the chances of them having an ovulatory cycle is very high. So we usually encourage them to exercise and lose as much of that fat as possible. Those who are very thin are encouraged to gain weight and just eat very well. Most of our diet contains multivitamins. Most of the things we eat. So you don't need to go extra mile to start looking for, products that you will take to help you to ovulate better, And of course, like I mentioned, if you are not married, just keep up with your regular exercise and maintain a normal weight. That alone will go a long way in helping to ensure that, you don't have those problems that can result from obesity or gaining too much weight, because many ovulatory issues result from either increase or gain of weight, or when a person loses weight so much that there will not be a problem in the hypothalamic pituitary ovarian axis, leading to an ovulatory problem. So it happens like that.
Okay, so this next question is very similar, Chief. Say, please, why is it that as female I don't see or feel any sign during my ovulation?
All right.
I think you even mentioned some. So please, yeah. We can hear you, Chief.
Hello. What happened?
Hello, sorry. I
I
just
think
want
the
to be
chief
sure
will
that
give
the
it to
person
us.
is also
Okay.
married. It's
Okay.
fine.
Okay.
It's fine. Like I mentioned, once you have established a regular menstrual pattern, you don't need to worry so much. If you are not on any medications like ovulation suppressing medications such as many family planning pills, you don't need to worry so much about ovulation. If you are desirous of getting pregnant, yes, you can walk into the hospital for a full fertility checkup. Otherwise, you don't need to worry so much about it.
The next one, I think Dr. Israel is here. Dr.
Thank you so
Israel.
much. Yeah.
And a
Okay,
woman
I think
can
it's
get
Veronica.
pregnant with one
Is
tube. You can give birth to 5, 10, 5, 10, many children with just one tube if the tube is not compromised. If there are no other
okay, I think
factors, the tube is fine, the ovaries are fine, you can get pregnant with just one tube. For those who have had ectopic pregnancy before that had removal of one tube, so the chances are also very high of having or becoming pregnant. Although it diminishes a little, but it still doesn't totally affect your fertility abilities, your capability to get pregnant.
okay. Thank you very much, Chief. This Ijoma is asking, when can someone that delivered through CS and the baby dies gets pregnant again?
Sometimes some things are very difficult to implement in Nigeria. Oftentimes, after birth, almost every woman is expected to wait till after 2 years before they enter into another voyage of pregnancy. Because particularly for a cesarean birth, the inter-delivery interval has to be at least 2 years, or inter-pregnancy interval of at least 15 months. So it's important because you are also considering trial of a vaginal birth for them. If the inter-pregnancy interval is short, if the woman eventually enters into labor, the chances that womb will tear at the time of labor is very high. So you allow them time so that the lower segment of the uterus can heal very well before the next pregnancy. So usually I advise them to wait after 2 years before they get pregnant again. And
Okay,
the World
please.
Health Organization actually advocates that after pregnancy everybody should wait till after 2 years before they get pregnant. But you see, in the context of that a person has lost a child, it becomes difficult, particularly in this part of the world, in developing part of the world, where there is pressure, so much pressure on the woman or pressure on the couple to just have a baby. So when it comes, we manage it the way it is.
That's true. Tonya is asking, please, can a woman with fibroid get pregnant?
Almost every woman has a fibroid. Yeah, almost every woman. One in every 3 women you see has a uterine fibroid. And many women with fibroid have been known to successfully achieve pregnancy and carry that pregnancy successfully without any problem up to term and deliver their baby successfully. But there are certain instances in which the fibroid can actually be problem. The fibroid can actually be problem. One of such instances is this: if the fibroid is in the uterine cavity. A fibroid can be so big and fill up the womb such that even when the sperm find a way to pass in between the womb into the tube, fertilize the egg, and once it's transported back, it becomes difficult for implantation to even take place within the endometrial cavity. You can also have some fibroid blocking where the sperm is supposed to pass, or increasing the time of transport of the sperm from where it's deposited to where it's supposed to fertilize the egg, thereby causing difficulty or even inability to actually achieve that pregnancy. So it's two ways, but the location of that fibroid is very key. Some fibroids that are located close to the tube can distort that tube and even cause tubal problem for the woman. But fibroids that are just located on outside the womb, like the subserous fibroid, just within the muzzle of the womb, too, many of them may not cause anything and may not prevent the woman from getting pregnant. And the only problem is that if the woman eventually gets pregnant, certain changes can occur, that may lead to probably pain, and some difficulties during the pregnancy, particularly when the fibroid is so big. So that's usually why they say when the fibroid is big, you perform a mammectomy, remove the fibroid, and then you can then go back to, the pregnancy voyage, and that's it.
Okay, Chief. One other person is asking. She said she has been diagnosed of endometriosis and had a surgery 3 months ago. So he wants to ask, or she wants to ask, if there would be well, let me would there
okay,
come
I'm reading.
Will this ever come up again? Okay, yeah. So it's asking if this will ever come up again.
You see, there are various levels of endometriosis. Endometriosis is one of the most difficult gynecological conditions to manage. One, the reason being this: patients with endometriosis, endometriosis is often associated with inability or difficulty with getting pregnant. And the medications that are used to manage endometriosis are anti-pregnancy medications. They are just anti-pregnancy medications. They prevent pregnancy. So you are left with two evil. So it's actually difficult. And sometimes endometriosis, even when they have been removed, can recur. So what you do, you suppress in every way, or as much as possible, the ovulatory cycle of that woman. And once that is done, the woman doesn't ovulate. And of course, if it's severe endometriosis, you won't allow her return to ovulation till about 1 to 2 years after the procedure is done. You want to totally suppress that process of ovulation, and that's where the problem lies. So it still depends on the managing gynecology to determine when to give that leeway. For some of the patients that have managed with very difficult endometriosis, we eventually end up doing assisted conception. And sometimes even donor insemination. And that's why that donor eggs and all that, because it's difficult to stimulate them to produce egg. That's why I'm saying that it depends on the level of endometriosis. We can only be determined by the person or the team, the gynecologist who manage the index case of endometriosis.
Thank you very much, Chief. And Patricia is asking, can ovulation problem be treated?
Okay, like I mentioned earlier, anovulatory problem is a common gynecological problem. And if I was speaking to this person directly, I first of all want to know whether the person is married or is single. And one of the best ways to manage anovulatory cycles is lifestyle modification for married young girls. Regular exercise, just cut your weight down by at least 5%. That weight should go down. If the weight goes down, the chances are very high that the ovulatory problem will return. If the girl is very thin, add some weight, it could also return. But there are medications for couples, very effective medications for managing anovulatory problem, particularly when you see that there are documented evidence of anovulatory problems in the couple, in the woman. So you manage the problems the way they are. You give ovulation-inducing medications. And that is when other causes of infertility have been excluded. You don't just stay on that ovulatory problems alone.
Thank you very much, Chief. Okay, and this other person is asked, please, can a woman diagnosed with polycystic ovary get pregnant?
Polycystic ovary is one of the commonest cause of anovulatory infertility. Yes, they can do very well when they are properly managed, and I mentioned that the major issues with them is that they are not ovulating. So, and that's where the medication for ovulation come in. A couple of other things may be added, because polycystic ovarian disease is actually a syndrome that may also lead to insulin resistance. So a couple of times you want to control the person's glucose to such a level that the glucose level is well maintained while you are still giving the ovulation-inducing medications. And it's one of those conditions that many gynecologists are very capable of managing. So it can be well managed, and then there are many patients with polycystic ovarian syndrome who eventually get pregnant. So they can actually get pregnant.
Okay, so Chief, thank you very much. I have a couple of questions. I don't know how much time we permit us to answer them. But I like the fact that you stressed on the male factor infertility, because these days most people they tend to even take the whole blame on the women. Our culture also shift the whole blame to the women.
You see, the condition of infertility can be very painful for those who are affected. And you see, it's made worse in Africa because of the very high fertility rate. You are living in a compound with, let's say, you are living in a flat with 4 couples in the flat. The 3 of those couples have 6 children, one has 7, one has 10, the one doesn't have. So it will not be masked as if this compound does not have any issues of infertility. That is the true situation of Nigeria. The condition is painful, but the high fertility rate in Nigeria and the high population rate has widened the gap of the problems of infertility. It's not difficult to understand the true burden, how pained a woman who is unable to get pregnant is because of the high fertility problems in the country. So nobody cares. Infertility investigations are very expensive. In regular hospital, to do a single hormone, take for instance follicle stimulating hormone, will cost you about 5,500. And once you are checking for hormonal profile, you need to do FSH, LH, prolactin, estradiol, progesterone, all that. That's already going over 22,000. Now you do a single HSG. The minimum you can get to do HSG in any radiological center will be about 22,000. And then only the basic scan you may get about 4,000, transvaginal scan about 5,000, 6,000. You see how that's just on the sideline or investigation. Now, if the couple is unable to get pregnant and you want to recommend that they go for an assisted conception, the minimum you can spend on an IVF just for a cycle will be about 1.5 million. Not the additional things you will pay for. So it's like that. So patients with tubal factor infertility whose tubes are blocked, the options will either be to do tubal surgeries, which the success rate in Nigeria is very low and is usually not recommended by many gynecologists. Oftentimes, women who have tubal blockage, they are commonly recommended, referred to have an assisted conception, IVF. The other option would be for them to what? Adopt a baby, which is a recognized way of managing tubal factor infertility. But you understand that we have cultural problems in Nigeria. We have cultural problems. So many people will not see the adoption as also a normal way, of having a child of your own. It's actually supposed to be one of those management strategies for tubal factor infertility. So these are the issues are much. So the infertile couple become so pained and missed other people. And when families begin to come in, the woman may be an outcast, may become depressed. The desire to even have intercourse now begin to dwindle. Have that
worsening the situation.
So it poses a lot of difficulty, and many couples, you have recorded several suicidal, attempts from inability to actually, achieve or to get pregnant. It's painful. The condition is a difficult one, and it's more difficult in Africa because of this.
Very difficult, Chief. So, but Chief, I wanted to ask, since most people who are asking questions are female and they're asking from female perspective, I want to represent the men and ask for the men, because male factor infertility, you noted, is 35%. That's massive. That's almost, that's much. So I wanted to ask, Chief, how much sperm is actually needed to fertilize to be able to impregnate a woman?
All right. For sperm analysis, in sperm analysis, there are some factors we look at. We look at the count, we look at the volume, we look at the count, among other factors. What people commonly look at is actually the count. Currently, the count has been reviewed to a minimum of at least 15 million. 15 million per mil, because the sperm volume should be about 2 to 5 mil. That means you must have a minimum of 2 mil, which is about 30 to 32 million, for you to say that, okay, this one is a normal sperm count. If you have about 15 million per mil, sperm count is okay. But if you have that 15 million per mil, and motility is 0, nothing will happen though. If the sperm are not moving, they can't move anywhere. If you're not there, not there. If you're not there, not there. I'm just telling you, you can have so much sperm, but the motility is very poor. What you're interested in is forward motility, the ones that are moving forward. Not the ones that are just there. You can also have abnormal forms, very poor morphology. You have very abnormal kind of sperm everywhere. You also find it very difficult for such sperm to fertilize an oocyte. So those are the factors you look at. You look at the volume, not just the count. You must look at other parameters. If the mucus is so much and bind the sperm together, it can affect motility. So you look at all other factors. But most important factor is the count, the motility, the morphology of the sperm.
Okay, Chief. So yes, so the thing is, that means 2 mils, at least 2 mils per ejaculum or ejaculation.
Is about 1.5 mil, at least 1.5 mil. Should be at least 1.5 mil.
Okay, so
1.5 is still okay.
So it's still okay. So everybody here, at least you can estimate what 1.5 mil is if you want to get.
See, outside that, the other factor that also important in male is this. Male factor infertility, previous surgeries is very key. Previous
I was surgery. Even going there.
Hemiography, prostatectomy, if the person has urinary symptoms and all that. And then another very important thing is this in male: age, background medical illness. Drug used to treat diabetes and hypertension can affect erection
Sperm
and ejaculation, can also affect the quality of the sperm that is produced. So
Chief,
those are
somebody
the
that
things
I've
you have
had
to ask in your fertility
somebody that
clinic.
I've
You
had
must take that history.
yes, somebody that I've had unilateral orchidectomy. Does it in any way reduce? I know it does not probably affect. Does it in any way reduce the chance of sperm production? I mean, reduce the rate of sperm production.
If the
Or what do you have to
testes
say
are
about
removed, unilateral, right, on one side,
just one, yes, one side, yes.
the other one can pick up the other one can pick up the production of the sperm. It can pick up the production. It can pick up. It's just that whatever has affected one is very likely to affect the second one. If you have a condition that may probably have resulted in removal of one of the testes, definitely the other testes would have become compromised.
So, but Chief, somebody have said that all those pre-ejaculum, all those little fluid that comes out during is enough to impregnate a woman. How true is that? Because somebody, at least I've listened to somebody who said, or who claimed that was what got her pregnant. At least I've listened. So how true is that? Is that little drop of pre-cum, as people call it, is it enough to impregnate somebody?
Well, I really can't say. I don't know what level of research has been done about it, but the truth is that even if there are sperm in the whatever they are called precum, the concentration may be quite below. Once you see the sperm, you will know that the sperm is coming out. You have a lot of secretions that are produced by the Kappa's gland, the prostate gland, and then that goes with the sperm. Some of those ones they call precum are some of those secretions that have been produced.
Fluids.
And so you can have some volume of semen, some volume of sperm in it, and you know that even if it's just a single sperm, it can still fertilize. If you have a good motility, you can still go there and fertilize. So I think a lot of work still needs to be done on it to see how much we can collect several precum and see how much of sperm the sperm cell is actually in it, and then we can pick up paper and say, yes, this is what it is.
Okay, Chief, I know we have spent more time. At least let me ask one more. I have many more, but let me just ask one more last question, and I think it's important. So now that we know that sperm quality, the quantity is an issue. So what are the things that reduce this or bring about this low quality of sperm and also the quantity? What reduces the sperm count actually? What are the things that reduce it, and how can men, some of the tips that men can do to prevent it?
Apart from what I've mentioned, usually they will tell so many men to allow that temperature affects sperm production. So they'll tell so many people, please don't wear nylon fitting pants, very tight pants that will increase the ambient temperature around that area of the testes. They also say that many drivers who sit on an engine for a long time, that particular area that is hot, and the chances of having abnormal sperm quality is also high. These are some of the things that have been proposed, but generally good diet and all that, will actually, improve sperm production. And of course, if there are no background medical condition, it's not diabetic, not hypertensive, not taking all forms of medication and all that. Yes. the chances that the quality of the sperm may actually be affected is low. And then there's a condition they call varicocele. A man having varicocele, so some of those conditions can increase the temperature around the scrotal area. That is why surgical interventions in males sometimes improve spermatogenesis and improve the quality of sperm. Tying some of those vessels that increases the ambient temperature, which will now, reduce the quality of sperm that are produced or reduce the volume of sperm that is being produced by the testes. So in any case, there are no just normal lifestyle modification is just enough. Take normal diet, do exercises, and others you need to do. They are fine. And whenever you have infection because of form of sepsis, genital tract infection, urethritis, prostatitis, and some other things, otitis, infection of the genital tract infection generally in male can also reduce the quality and the quantity of sperm that are produced. So proper treatment is also advocated in such instances.
Okay. Thank you very much, Chief.
Thank you very much. I
Right.
know we are supposed to
in childhood, then there's a condition they call mumps otitis, that eventually affects the ability of the testes to produce sperm. But generally, when you examine the testes and see that probably one of the testes is smaller than the other, it's an indication to perform further investigation to see what the problems are, so that you see how to probably tackle the problems if they are there. And oftentimes, when you have such testicular abnormality, you can then call the urologist to co-manage with you. Yeah, you can refer them appropriately. That's why they even need to come. Getting the men to come to the hospital is the biggest challenge any gynecologist will ever have.
Yeah.
They can be very difficult.
I don't know if I still have time to ask one more question.
We have
so many questions.
I wish we had enough time. These programs are usually 1 hour, and we have to extend it because of this topic. There are so many questions. I don't have to ask.
We also started late.
Yes. So yes. So I want to ask something, sir, because of some here. 2 in 1. The first one is, some ladies have complained that the reason why they cannot get pregnant is because whenever their partner ejaculates in them, it always comes out. That is one. That reason why they are not getting pregnant is whenever the partner falls in, it will come out. Or they claim that the ejaculate is watery. That is why they can't get pregnant. So please, sir, what do you have to say concerning this complaint that they have?
That's an everyday complaint in the hospital. When you come to fertility clinic, it's the very first thing you will hear. Even when there's no ejaculates, even when there is no single sperm cell in the sperm, that's what they see. Even when, for a woman who has tubal blockage, the tubes are blocked, she still sees the fact that the sperm pours out whenever the man ejaculates. But we usually, probably counsel them, yes, the woman may be right in her own way because she is the one that sees what happens in the house. But also, we also need to tell them that, yes, what the man just need to do is to deposit that sperm in the vagina, and that whichever one of the sperm that wants to move inside, the tubal cavity, it doesn't matter, even if the semen, you see the semen pouring out, it's possible that that sperm has already gone in. So we don't stay on that fact. We reassure them and do a proper evaluation on the man, and then do a proper evaluation on the woman. If the sperm is adequate, we don't bother them so much. We just encourage them, okay, after the intercourse, you just stay. Sometimes you can find a pillow, pull up your leg and just wait. Don't keep jumping up whenever you've had intercourse. Just wait, give it some time. Within 1 hour, whatever it is would have gone to where it's supposed to go. So it's just to continue to reassure them, because it's difficult to actually convince them that it is not whatever is pouring out that is the problem.
Thank you very much. Dr. Oze, do you have any final question to ask? Because I don't want us to extend this. I wish we can extend it, but we don't want to extend it so that we can have another session. Or if I may ask one more, sir. Tubal blockage. There is this belief that when a woman's tube is blocked, they can flush her tube for her and open it. Most women believe that, oh, I was tubes that blocked, so I went flushing of the womb or flushing of the tube, and I believe I will get pregnant. What is the probability that this would work, and does it even work at all?
Okay, there are different levels of tubal blockage. There are different levels of tubal blockage. It could just be fibroid adhesions, fibroid agglutinations, you know. But if those are distal tubal blockage, you know. But if it's a proximal tubal blockage, that real tubal blockage, it's an all or none thing. That tube is blocked. No amount of flushing, we opened up that tube. There's no amount of flushing, we open up the tube. But if it's just small tubal agglutination, probably a mucus was blocking that fibroid end of the tube. It's possible that with such pressure, the tubes, the mucus could actually be dislodged. But it's difficult to say. It's difficult to say. Once a tube is blocked, and you've seen that from an hysterosalpingography, the options available for care are not many. One of such options is to do a tubal surgery, and that's only when it's just a distal tubal blockage. Maybe fibroid adhesions, break the adhesions, and fibroid agglutination and all that. Just distal tubal blockage, and the success rate are very low. The success rates are low. The risk of having ectopic pregnancy, even when it becomes successful, are also low. So many people will refer for an assisted conception. Mind you, there could be other option, which is at least an adoption. We decide to adopt a baby, which is still a way of managing tubal blockage. Some people may tell you that they had told me that my tubes were blocked and eventually I got pregnant. It's possible. Reason being that sometimes during investigation for tubal factor infertility, the tube can undergo spasm. When you do an HSG and the tube undergoes spasm, you would think that tube is blocked. And if the person eventually gets pregnant, he will come back to you and say, this one is a devil's advocate. He never wanted me to get pregnant. So it happens like that. That is why sometimes to actually confirm tubal blockage, it's better to perform a laparoscopy and dye test. When you perform laparoscopy under direct vision, you're able to see the dye, that if the dye spills, that's one, and also help you seal peritubal structures. If there are peritubal adhesions, if there's endometriosis and all that. So even if they had told you that the tubes were blocked using your HSG, it's still good to perform a laparoscopy and dye test to see if probably that blockage they saw was due to tubal spasm or some other things.
So there's someone asking, what do you mean by assisted reproduction? Yes, sir.
Assisted conception, helping the woman now to conceive, because the tubes are not open for spontaneous conception to occur. By that way, I mean an in vitro fertilization or other techniques. There are many other techniques. That's why I'm calling assisted conception, depending on the abnormality you have observed. So it requires taking a sperm from the male, taking harvesting an egg from the woman, and fertilizing it outside, and then putting the embryo right inside the womb. So it's because you are not allowing the spontaneous, process to occur the way it usually does. you are assisting it to happen because there's a break in that mechanism for it to occur physiologically as it would have been.
Okay. So thank you very much, Chief. I think I should ask this question last. I know we have spent a lot of time. Fertility is very broad and it's becoming a very interesting discussion that even to go is, but we just need to go. But Chief, I know that some people may be wondering or some people wants to know this concept of safe period in a menstrual cycle, as in when it's best time in particular menstrual cycle to actually meet your spouse in order to achieve pregnancy. So can you just throw more light so that people can, maybe if they could explore that knowledge, or if
Option.
anything like that even
Okay.
exists? Yes.
Well, these days, it's young girls that are married that ask more questions about unsafe period because they continue to have sex. They don't even think that there are other issues with sex other than just,
That's true.
issues of sexually transmissible
Actually.
infection, unwanted pregnancy that will lead to unsafe abortion, and so many things that will eventually compromise their fertility potential. It's important to
Yeah.
always let the young ladies know that no, it's not just the pregnancy. The chances of other probably worse consequences happening are higher, particularly when they are not sure of the number of partners their partner, the male, is having, or even they are having. So that barrier contraception before marriage is very key. Condoms are very good. They are beautiful condoms that can look like as if you are using your normal skin and all that. So we should always encourage that for people who are unmarried. Married people are supposed to enjoy intercourse without condom, and that is fine. All right. That being said, we know that people who menstruate regularly, who have a regular menstrual cycle, let's say a 28-day menstrual cycle, their ovulation usually occur at the mid-cycle. The period between ovulation and the time you menstruate is usually constant at about 14 days. It's almost always constant about 14 days. Once ovulation happens, after 14 days, the woman will menstruate. That's usually the pattern. So for women who have regular menstrual pattern, it's important to time it like that. So what we do is to encourage them. They can have intercourse alternate day from day 8. The sperm can stay in the vagina for up to like 72 hours. So for couples who have alternate day intercourse, as in have intercourse on day 8, have intercourse on day 10, have intercourse on day 12, have intercourse on day 16, it's difficult to miss that ovulation period. You don't just wait for that day 14 alone to go and have intercourse. No. The idea of having intercourse is not just to get pregnant alone. Intercourse is meant to be enjoyed too. And that emotions and all that are still there. But we encourage couple to meet alternate day from day 8 is just fine. Because if they meet from day 8, day 10, day 12, day 14, day 16, it's difficult to miss out the ovulation period, even if you decide to come earlier or a little bit later. It's difficult to miss out. So not just waiting for that mid-cycle to come before you have the intercourse. But for gynecologists managing them, they can study them over time. They can even look at their cycle for a period of about 6 months and then advise them based on how their ovulatory cycle is, particularly those that have irregular cycles.
Menstrual
Many
cycle.
patients you will find in fertility clinic will have an abnormal menstrual pattern, an unusual menstrual cycle. So it's only when you carefully monitor them over a space of time, you cannot calculate and know that yes, it's like this is their regular pattern, this is how you are going to do it, and that's how it's going to be. But if you maintain that alternate day intercourse from that day 8, day 10, day 12, just probably to day 18, you see that there's no way, it's difficult to miss out that ovulation period. And once sperm is deposited, it can last for a minimum of 48 to 72 hours within the genital tract. So it's difficult to miss out. So
All right.
it's,
So
it's,
Chief,
it's an important aspect, and I must encourage every couple who visit that gynecologist to continue to ask questions like this, because it's still at the fertility clinic, they will calculate it better and then probably let you know that this is it, this is it, this is what it should be, and all that, because cycles vary for different women.
thank you very much, Chief. I think at this point we have to start calling it a day.
Yes,
We have to call it a day because we have
we
spent
have
so
to.
much time here. Maybe we can
Thank you.
reschedule this
Thank
discussion
you.
again, because I
Another
know
part
we have
too.
so many people, many questions that we were not able to answer because of time, and some of these questions were asked in the last period, last week, or last in our last section. So, Chief,
Yes.
please, we can always call on you to help throw more light on topics like this maybe later on, but for now we need to just put it to a close. That is not a very insightful one. I believe everybody here have learned one of two things. Even me,
Hello.
we have all benefited one thing or the other. So maybe Chief, Dr. Fred, Chief, if you want to just give us a final word, and then while we draw the curtain.
Yes, sir. So, sir, the floor is for you, sir.
I didn't
your
hear
final
that.
words. So we want your final words as we round up tonight, sir.
Okay. Okay. I just want to mention that infertility is a worldwide problem. It's a worldwide problem. Infertility doesn't affect just developing countries alone. The problems of infertility cut across every part of the world, both developed and developing part of the world. And then, secondly, it's important to still mention that the condition posed by infertility can be a very painful one for many couples who have this problem of infertility. And we must share these emotions and be able to effectively assist them in whichever way possible whenever we see them presented to us in our gynecological clinic. That's what I want to say. We must share from their
Okay,
emotion
thank
and
you
be
very
empathic
much, sir.
when evaluating and managing them.
So thank you, sir.
Thank
Everyone, I believe we have heard what Chief has said. Thank you. It's been a very beautiful section. I believe everybody, and we are sorry for everyone whose question we are not able to answer today. Dr. Fred Abi. So we'll just deal with it like we said earlier on. We could just deal with it in another section.
Yeah.
So if Chief will oblige us that opportunity
And
again.
also, some of the questions they are asking was discussed in the previous video last week. So they can also watch it, or when you rewatch this video, you get some of your answers again.
And also thank you all for your very nice comments. We see nice comments here saying that it's a very educative one, encouraging comments. So we thank you, and I will hope we could do this some other time. Dr. Fred, Dr. Israel, over to you. Chief, I am honored. It's always nice having you around us. Thank you very much, sir.
I really don't have much to say again, rather than saying thank you. Dr. Israel.
Hello.
Thank you so much.
Thank you, everybody. We have to go now. We want to appreciate Dr. Joseph Okoeguale, a consultant obstetrician and gynecology from the Israel Specialist Teaching Hospital. He was among our teachers while we were in medical school, so we just have to put that here. So we really do appreciate you, sir. Thank you very much. And like we always say, good life in that sense. Posting this video immediately we end now. It will be on Facebook and it will be on YouTube. Please share with your friends, your loved ones, and let them gain from this knowledge. Thank you once again and have a lovely week. Good night. Bye-bye, everybody. Thank you, sir.